Hey, thank you. I'd like to welcome everybody and call the meeting to order for the Board of Commissioners of Whidbey Health. This is our regular board meeting. We do encourage the public to have comments, so everything being recorded, and if you do want to state anything, you have to just kind of get through to John, raise your hand, or you can text him, email him. You also get whatever comments you have. If you do have comments, please limit it to like 3 minutes or less. So at this time, I'd like to start off with our consent agenda.
Move to approve the consent agenda.
Second. Any discussion? All in favor?
Aye.
Okay. So moved. Are there any points of order that need to be brought up? Hearing none. We'll move on. So just to make sure, you said Greg is
Waiting another round.
You'll be here.
Oh, he's here now.
okay. Yeah. Okay, so just wanted to welcome Greg, one of our commissioners who's online with us today. He won't be at the meeting, but he'll be attending on the virtual one. So that we'll move it on to medical staff report. Do we have Dr. Lemmy available?
Is Dr. Lemmy on?
No, we told Dr. Lemmy to go in the.
He's waiting in another room.
So is he going to come in to do his presentation?
Yes,
At what point?
when we reconvene from the executive session.
Okay. Okay, so we'll move off of the medical report till then. And we'll move on into health tech report. Neil, welcome.
Hey, thank you very much. Why, good afternoon. The first thing I want to do is introduce Dominic Sines, who's partner with our health tech team. Dominic heads up revenue cycle and then also the staffing side of our equation. He lives in Southern California and has been part of our team now for almost a full year full time. About a year and a half, close to 2 years on a part-time basis. I just wanted to introduce Dominic, and I didn't know whether you wanted to say a few comments.
No, thank you, Neil. It's wonderful to be here. I'm very excited about the future with Whidbey, and thank you for having me.
Good. Why, I just wanted to, you have our printed report in your documents, but I just wanted to touch on a few things. As far as the permanent CEO search, Peter Goodspeed has been sourcing people now since the middle of November. We have several candidates. I think he has listed 11 on this document, but it's actually higher than that right now. He's in the process of Zoom interviewing all of those candidates. And then once he does that, both Dominic and I will be Zoom interviewing the ones that after he's screened and vetted those, and then we will do additional screening and vetting on top of that. Our plan right now would be to present the candidates that we've screened and recommend to you probably on January the 5th, your work session, and we would do that by Zoom so that we can go through those resumes. We will get the recommended candidates to you prior to that on their resumes so that you've had an opportunity to review those. So we'll get those to you soon. We've had a good response, and we have some good candidates that hopefully we're going to materialize. I did want to mention John Freeman's here. He's been here and he's going to be here through Saturday. Our associate vice president, and he's working with Paul and the team on the financial side of the equation, and Paul can address some of that in his report when he has it. And I won't delay the meeting, but I did want to mention Joyce Smith continues to be here and has been working with the business office, Paul's team, and also working in the clinics, trying to improve operations and billing aspects of the organization. And then Faith Jones was here actually Monday and Tuesday this week, working with the clinics on the care coordination, which is the Medicare chronic care piece. And then also, PPM, which is, the specialty side of the chronic care equation. And those are programs that were actually instituted and approved by Medicare, CMS, probably about 4 or 5 years ago. But we've had a lot of success in implementing care coordination because it's a wonderful thing for Medicare patients that have a chronic care condition or have enhanced service, and then the practices are actually able to bill and collect on those services, which heretofore they haven't been able to do so. And it's been a good thing for the practices in the hospitals, but more importantly for the patients. Other than that, unless you have any questions, there's a listing of webinars we have coming up for our staff. We've been here meeting with the team and reviewing the action plan that Mike and the team have put together and going forward.
I don't know if Mike wants to add anything to that report, but I do want to say that, you know, it still amazes me on. You know, we're not hiring health tech just to find us a CEO. That there's a whole team here to help us to rebuild and really make it to the next step. So we really appreciate the in-depth thing and what all you bring here.
Yeah, and I would just go comment that your team has been doing a very good job identifying opportunities and moving forward. I mean, we think back to March, things weren't so pleasant, and I think now although we still have a lot of work to do there, you know, at least there's some opportunities and it's looking much better. So, you know, unlike I know Mike might talk about the Washington Hospital Association report, where there's a lot of challenges with Washington State Hospital.
Yeah, every day you pick up the newspaper, there's something else in there about all the hospitals struggling to spend that.
Yeah, there's a recent document that came out by an organization out of Chicago that they've identified close to 900 hospitals throughout the United States that are in jeopardy of closing in the next couple of years, which is pretty dramatic. When you think about it.
There was an article that just came out in the newspaper in Seattle. By the Washington Hospital Association put it out, but it just shows the operating margins that hospitals in 2021 in Washington had an operating margin of -1%, so they're already losing money. Now that operating margin is -7%. So that it's really moved. And then I was just looking at some other points here. Net income in 21 was $1.3 million, or $1.3 billion, I should say, for the Washington Hospital Associations, and that's $2,576,000,000. So it's really just dropping off. A lot of hospitals are forecast to go out of business. Could come in since March and solidify things. So we think we've got a really good chance now to move forward, and we're forecasting in the budget that we just gave to you about a $400,000 loss for next year, which is incredible. And today we've got about $16 million in cash on hand. And Paul will give them more report on that. Well, we've come a long way, and just wanted to say that we have had some really, really good consultants in here. Joy, the fact that he was talking about it really helped us streamline operations in our clinics and in hospitals.
I just appreciate the involvement and the commitment that Health Tech has made. And, you know, we're a remote hospital way out in outskirts. You know, we're getting your attention. I really appreciate the fact that you're not looking at us more like a stepchild, that you're actually taking it to heart. And I have seen that from the whole team that you provided, that they take it to heart and we really are working hard and pulling this together. So timing wise, I think it happened, you know, for us at the perfect time. And we had this time to start getting things turned around before it has gone to the disaster that you're seeing right now throughout the state. So
Yeah.
I think timing wise, it came right on board. So I did make a mistake. I think we have to adjust our schedule. We need to go into executive session now, then later on. And it's for informative session. Mike, do you want to do that in another room?
No, we just want to ask everyone to leave here, and then this should take about 15 minutes. You know.
Sorry about that, everybody, that we have.
That's okay. That's okay.
And we'll come back in and talk about 15 minutes.
Okay.
Yeah, now we're good.
If Dr. Lemon's back up.
And recording?
Yes.
Okay, well, welcome back, everybody. We had things in the executive session, nothing to be reportable at this time on any action, and we'll go right into medical staff report. Dr. Lemmy. Agent Dr. Lemmy. There we go.
I think I'm been promoted to a panelist and unmuted now.
Yes, we can hear you now,
We can hear you.
Good. The Credentials and Bylaws Committee has recommended initial appointments of James Kuo, DO, telehospitalist, provisional. Brian Minow, MD, family medicine and wound clinic, provisional. Teresa Murphy, MD, internal medicine, PC Freeland, provisional. And Nona Hansen, MD, family medicine, the walk-in clinic, Goldie, provisional.
Your motion to approve.
Move to approve the initial,
Appointment.
initial appointments.
Second.
Any discussion?
Aye.
All in favor?
Aye.
So moved.
We recommend advancements of Patel MD, telepsych courtesy, and Robert Swan, a nurse practitioner in family practice in the walk-in clinic, to active.
Move to approve the advancement.
Second.
Any discussion? All in favor?
Aye.
So moved.
And we recommend reappointments of Adrienne Fain, CRNA, anesthesia, active staff. Carla Jolly, nurse practitioner, palliative care, active staff. Lance Kais, DDS, oral maxillofacial surgery, active staff. And Megan McSorley, MD, OBGYNs and OBGYN surgery, active staff.
Move to approve the reappointments of these active staff members.
Second.
Any discussion? All in favor?
Aye.
The MECs moved to remove NRP, which is neonatal resuscitation program training, as a requirement for CRNAs, because their training that they get as a CRNA exceeds that it's required for NRP. NRP is designed for primary care pediatricians and family physicians, for the most part, in taking care of neonates in the OR. And what CRNAs are able to do is it surpasses that. And so doing that kind of training and maintaining that qualification is superfluous. We recommend the board approve that change to make it easier to keep our CRNAs up to speed.
Recommend approval of the removal of the neonatal resuscitative program as a requirement.
Second.
Any other discussion? All in favor?
Aye.
So moved.
The bylaws committee has reviewed our current bylaws and had legal review of them as well, and they're ready for review by the board. I will have those sent to the board members, and we'll anticipate approval of those at your pleasure at the next board meeting in January.
Will we get those early enough that we can actually have time to read them?
I will have Heather send copies to all the board members today.
Thank you.
Then we can discuss it at our workshop. If we have to vote on it, I think our regular
Yeah.
board meeting, that gives plenty of time. Okay. Anything else?
And that's all I have for today. Thank you.
Thank you. Moving on, we're going to bypass the quality and compliance report. Janet can be here a little later. We'll move on into operations and outpatient service. Dr. Miller, our COO.
Good afternoon. As I think you already know, we have reopened our Freeland Primary Care Clinic as of December 1st. We have NP Cadis and NP Johnstone working there now, going well. And we anticipate having Dr. Murphy, who privileges you just approved. He will be starting at the end of this month and he will see patients early next month. As an additional provider, full-time provider. We still have primary care services at Clinton on a part-time basis with NP Badler, Dr. Gavin. On the recruiting front, we came very close, but we're ultimately not successful in recruiting the urologist that you all heard about. It was a personal decision based on family, professional. The job was very attractive to those families. We are actively recruiting orthopedic surgeon, have 2 candidates that we're looking at. Behavioral health, we have 2 nurse practitioners we're looking at. OB/GYN, we have 1 candidate. Primary care, we have 1 candidate. We just approved Dr. Minnows privileges to be starting at the end of the month in our wound care clinic. They're still actively recruiting a general surgeon, still having good candidates at the moment. And you approved Dr. Hansen, who will be starting in our walking clinic on a per diem basis sometime soon. We are interviewing a rehabilitation manager candidate tomorrow to fill that vacancy we have in our rehab department. Other significant updates, Frisia is going well in our Athena Bay clinic, and we're building it out in our Meditech clinic departments. Hope to go live with that next month. Telehealth, just to remind you all, we currently do have telehealth services in our ED, telepsychiatry, telestroke. We have telehospitalist service at night in the hospital. And we're exploring telehealth services on the outpatient side. Help us with the demand on our ED and walk-in clinics to try to relieve pressure. More to come on that as we explore the opportunities that are available. I think this is my report.
One question, if I could, Dr. Miller. It was difficult to hear you. Did our urology physician candidate accept or did not accept?
Did not accept.
All right, thank you.
Can you talk a little bit about the telehealth for the nighttime hospitalists, how that's working, or should I defer that to Curtis?
I think Curtis would be better able to answer that question.
You want that now?
No, they can wait until his report.
That it? Moving on. Moving on to our finance report. Paul.
Yeah, thank you. Good afternoon. And I'll start with this comment. We are presenting the October financials here on December 15th. And my goal in the coming months is to reduce the amount of time that it takes our accounting department to close a month, so that by maybe February, the February meeting, we will be presenting to you January numbers. Okay, right now there's a 2-month lag, and that's just too much time. On to the October numbers. Highlights of the balance sheet include an observation that I made. Current assets, 41,409,000. Compared to current liabilities of 18,026,000 is a delta of about $23 million more current assets than we have current liabilities. If you look at the prior fiscal year end, 32,568,000 in current assets and 29 million in current liabilities is only a delta of about $3 million. So there has been tremendous progress made with respect to improving what we call a current ratio, which is the ratio of current assets to current liabilities. And that's a very positive, thing to point out. Moving on down to the statement of revenues and expenses. You see net patient revenues for the month of 8,213,000 and total operating revenues of 9,251,000. Total operating expenses of 9,000,003 and a net operating loss of 85,803 and a total net surplus of $129,369 loss for the month. And a couple of the contributing factors to that loss include we're seeing more ER volume than we were in the prior year. And we're also seeing more clinic revenue, but we're seeing less inpatient revenue and outpatient hospital revenue than we saw in the prior year periods. We've got a year-to-date total net loss of $962,948. And I'll talk about those charts off to the right, and if you would just go back up a little bit, John. We'll take a look at net days and accounts receivable. Has gone from 80 days to collect an outstanding accounts receivable account on average down to 59.6 at October 31 this year. Total hospital operating margin of a 4.3% loss. And days cash on hand at 53.6 short term and 54 all sources versus what you see in the red areas at 22.2 and 25.2 in the prior year periods. And we're seeing a little bit of an increase in our salaries, wages, and benefits as a percentage of net revenues in comparison to prior year, 53% versus 56.6. And this is largely the results of our efforts to be more competitive with recruiting, being able to recruit staff. So we've had to, and we are continuing to address those hard to hire positions where we need to make adjustments to the starting pay rates. If you go down a little bit, you see discharges 69, ER visits 1,725. Surgeries are also lagging behind prior year, and working paid FTEs of 465 and 529. And near the bottom, you see it that we're running an average daily inpatient census of about 10 and 12.4 on a year-to-date basis. And do you have any questions about that page before we move on to the cash flow forecast?
Yeah, going back to the very first page,
Yes.
there is a $24 million versus, or $20 million difference between previous years and this year. It's at the very first page.
Yeah, there you go. Okay.
Yeah, in like long-term debt.
Yeah, long-term debt.
Yeah.
Yeah.
So
Okay.
that's $20 million that, we are more in debt now than we were before.
Right. There was some bond funding that occurred this year. I believe the long-term portion of some leasehold improvements are in that number too. And offsetting that increase, though not dollar for dollar, is a reduction in current liabilities from 29 million down to 18 million. And on a total liability basis, you see an increase of about $8 million.
It just seems that, we're talking about looking better, but we have, like $20 million more long-term debt.
Right, more long-term debt, more cash. And that's that was an effort on the part of everybody to make us more liquid to this point where we can have some options when it comes to deciding whether we want to buy equipment.
So it was that loan that we got.
Yeah.
From the bank early on. So that's one thing. And then going down to the percent of our cash that goes into the salary and benefits.
Yeah,
I think it's a little misleading when looking at these numbers in terms of how many open FTEs we have.
right,
So it may not be as bad as it could be in terms of the total amount, but if you're 100 personnel shy,
Yeah.
if we were at full strength, and I wonder whether it would be useful to include maybe in those blocks the number of open FTEs.
Mhm.
Unfilled FTEs, because if Dr. Miller ends up getting all of these folks hired,
right.
that's going to shoot that.
It would, except you'd see an increase in the denominator as well,
Yeah.
which would be revenues.
Yeah.
Yeah, so, but your point is well taken.
We need to actually present the number of open positions every month. That's a fair question if you want to ask that.
Yeah, I think that's helpful because like we're at 27% turnover this past year or something in that neighborhood. And, that seems higher than the national average. And, we're working hard and talking about retaining people and that sort of thing. And it's more than just the salaries, evidently. So we don't really have a full picture in the same way that if we had more numbers, and Shannon certainly knows, that I asked the question about how do you compare, which is again, looking at the numbers here, we're comparing with last year and the year before, which were COVID years. Is that a fair assessment of how we're doing by comparison? Or do we need to go back to 2009 or 2019?
Right.
To have a more accurate comparison of when, people are not in isolation and that sort of thing. I don't know. It's more a question than.
Well, that 2019 data pre-COVID exists, and we could present comparisons of current.
Well,
year.
if nobody else has a question, then it may just be, my curiosity more than anything else. But I think as we're looking at numbers, it is important to compare apples.
Right.
And not the fruit.
To your point, in the months to come, we are going to be able to show on these reports a comparison of the actual to a real budget, which we don't have in these reports. We're looking at the 2021 budget numbers here. So yeah, everything is relative.
The longer you're here doing the business you're doing, the more we will understand that we are getting better.
I think so. We've got a long way to go. We've only begun. And that is very true. John, take us to a cash flow forecast. So This report shows a beginning cash balance of a little better than $17 million. We're forecasting cash receipts for the month of $9,246,000. And disbursements. One down. Of $10,870,000 and an ending cash balance of $16,086,000. And you look at that and you say that's a decrease of more than $1 million. And the item that sticks out is in the cash disbursements section, the fourth line item up from the total cash disbursements line. And that is the CMS settlement 2022 cost report. And I believe I shared with this group at last month's meeting that we had learned that we have a $3.1 million obligation to pay CMS back for overpayments that we received this year. And we met in the finance committee yesterday, and we'll be making a recommendation to the board to actually speed up that repayment from December and January at $1,561,000 each to pay it off now, which will save us considerable dollars in interest that CMS is charging us at 9%. Yeah, so that's really the reason for the decrease in cash from where we began the month to where we end the month. And other significant items in this forecast include roll us on, John. Right there's good. Notice payroll net under cash disbursements is increasing from $3,000,004 in the month of February to $5,691,000 in March. And the reason for that is we're funding 3 instead of 2 payrolls in that particular month. And one other thing worth pointing out is the overpayments that we've received this year from CMS have resulted in a reduction of payments going forward on the business that we do. And those reductions in cash receipts are reflected in that second row, Medicare rate adjustment. Going forward, they're paying us less than they were prior to learning about this $3 million repayment. So at the end of the day, and this is a 5-month forecast, and you go down on just a little bit. I thought that's probably John. You've got an ending cash balance of $11,499,512, and days cash on hand go down a little bit more of 36, going from 50 to 36. So from this point forward, from April forward, we've got we will have all of our CMS settlements 2022 and 2021 repaid, and we should start to see all things remaining the same. Days cash on hand begin to improve again.
Once, I don't know if I understood you correctly, but once that CMS debt is paid off, does that mean that that we will get more per visit?
No,
We're always gonna be lower now?
we're gonna be lower now until the final cost report for 2022 is tentatively settled, and new rates are provided at that point. And at that point, they could go up and they could go down. But there will be another change in those rates.
And and that's based on the hospital itself, not on the national.
Yeah, it's based purely on the hospital. Our ratio of costs to charges, or our ratio of cost to patient volumes, like how much is it costing us for a patient day on med-surg. And if it's costing us more than it used to cost us per unit of service, we would get a payback instead of a payment to that. So,
And the interest rate on that is 9%. Is
Yeah.
that right?
yeah, not nine, give or plus a couple points. Which is considerable on
That's expensive.
$3 million.
Yeah.
Are they part of the credit card business?
You would think. Any other questions?
No questions. I would ask Jim, you've been involved now with the finance group, the finance committee, your chair, and you've been working with them. What's your take on how the reports are?
Well, it's amazing what Haltech has done for us on the financial reports, because everything is becoming a lot clearer. Like Paul mentioned, we have a long ways to go. But it's each day we're getting a little bit closer, and
Might pull your mask down, so people.
we had enough cash on hand to meet our bond obligations, which were several $1 million. We paid that off. Currently, our patient revenues are down, but we anticipate that they will start picking up, particularly in the month of December. And we are anticipating that as we get our financial billing and coding straightened out, we'll be doing a little bit better. It's important, I think, we discussed this quite extensively. It's important that we pay off the $3 million immediately to avoid 9% interest, and then we will have $1 million left that we're going to owe Medicare for 2020, and we anticipate we will pay that off in March when we start to get the levy revenues in. So I would entertain a motion at this point.
Yes, I'd certainly like to make a motion that we pay down our debt for the CMS in 2022, which is $1.56 million and $500, I guess. Then we pay that off to avoid that 9% interest rate.
Three million.
3 million, that's right, total is 3 million, right?
And it won't be those exact dollars, it'll be something less than that, maybe to the tune of $400,000.
Okay,
And that's because they are presently withholding money from us when they pay us.
So it'll be south of 3 million, somewhere in, not exceeding 3 million.
Pay off the bill.
Yeah.
Yes. Okay, I would second that motion.
The motion, is there any discussion? All in favor?
Aye.
Aye.
Move.
Thank you.
Thank you.
Any other comments? Eric, do you have anything else on finance you'd like to comment? Or?
no, I think it's great that we're paying down our debt now, and I think that's gonna be pay this thing off in March. It's gonna be just very good, and we certainly have to thank our public for the support that we've had from the hospital in supporting our bonds as we have, so that's wonderful. And Health Tech is really holding down on our costs, and we really appreciate that very much too. They're doing a great job for us.
Did you have a comment or?
Yeah, it's a lesson learned. And in fiscal year 2019 and 2020, the hospital at that time did not do mid-year cost reports. So based on some historic ratio of cost of charge, the hospital has now been overpaid for 2 years, and we got it settled up. Going forward, we will do mid-year cost reports and should not get in this mess.
Like I said, I really appreciate what they brought to the organization. It's really paying off and working out really. Thank you. Don't want that to go to your head, Neil.
Yeah, we worry every day, so don't. Yeah, go into our head, I assure you.
Like I said, I mean, I do, like I said, I can't say enough. You really provided us with a great team.
And I can't tell you. The financial side of the equation has improved dramatically from when Mike got here. I mean, Jim Childress did a great job helping us. But again, they were pretty handicapped with lack of skilled people to do the job. And I think we're heading in the right direction, trying to provide you with not only current information, but accurate information. And that's been our struggle for the last, since we've been here. We tell you where we think we are, but we're not exactly 100% sure where we are. So I think we're getting where we have more comfort. I know Paul is working on the balance sheet, trying to make sure reconciliations are correct. So we still have that challenge, but we have some comfort that in the next couple of months that will be, those numbers won't be soft anymore. So.
Thanks. I just wanted to address something that you raised earlier on, Greta, with regards to employee retention. Amongst our other clients, hospitals, managed hospitals, we're seeing an average of about 20 to 25% versus the 27% that you raised earlier on in those analytics. That excludes nursing. So I don't know if La Jolla has any stats on what the averages are, but that's what we're seeing against our clients. And I thought I'd just mention that to you.
Thank you. Moving on to our IT, I'll make that back up. Cameron's now here. So we'll go back up to quality and compliance report, ma'am.
I had a question before it was on, actually.
Yes.
Was it not an indication that we wanted to tighten up on our balance sheet, and do we hire or approve hiring of people to look particularly into the?
Oh, absolutely. At some point, I hope we like those companies that.
We do, typically, Mr. Chairman will ask about a contract. We do have a contract.
Yeah, when it comes to the contract
In front of you, we would like to get approved so that we can reconcile our balance sheet.
Right,
So, I don't know if you want to do it at this time or not.
Why don't we do that when it comes to the
Okay.
contract?
okay.
Thank you.
Yep.
Hello,
Thank you for remembering.
is that okay if I stand so I can see the screen?
Absolutely.
All right, John's bringing up the slides. So reporting on quality for December. Go ahead and advance to the next slide, please. Thank you. All right, in review of policy medical at the end of October, we're less than 22% of policies overdue. That is a great step in the right direction for the organization. Medication safety, less than 1% of the medications administered in October resulted in a medication event. So to date, we're still below the national average rate of 8 to 10% for the year. For falls, 4 falls in October within the organization and 1 had interventions. So year to date, 48% of the falls, while the patient is ambulating or standing, have resulted in a fall here would be health, which is a testament to our increased rounding and safety measures that are in place. So inpatient falls are below the national average also for Whitby Health. For workplace violence, we did decrease events for October at 6. Different locations are listed. Year to date, we are at 63 workplace violence and 9 staff injuries. So we are continuing to partner with WISHA for training for our providers and staff in January and February. This is a mandatory training, and these are real life scenarios with situational awareness, as we're seeing an increase. For restraints, our objective is set at 90% compliance. Our restraint documentation compliance did increase in October, and this was recognized when DNV came through our accrediting organization. For infection prevention, COVID is national and community transmission levels are holding steady. However, for Whitby Health, we are not changing our masking and social distancing at this time. RSV is still substantial nationally and in Island County. And also, it is the worst flu season in several years, nearly 10 times higher than 2020 and 2021. For HEDIS, we are working with our payers to assist on care gaps for our patients. And we have released the Free to Health campaign to 1,252 would-be health patients regarding their screening mammograms. So they can call and schedule those directly. For accreditation, I do want to spend a little bit of time on this as we had a successful D&D survey for 2022. All 10 findings from 2021 were closed out for Would-be Health. We had 4 total findings for Would-be Health Medical Center. We had 0 findings for surgical and orthopedic care clinic. And they were very complimentary on our processes and patient care. The surveyors will return in June of 2023 for our next annual survey. So congratulations to the entire team here at Would-be Health, the leadership for really dedicating for accreditation readiness.
Well done.
Thank you. Well done, everyone. It takes a team. Patient safety and risk mitigation, our increase of events were for employee illnesses and also for documentation. The risks to the organization did stay the same, critical staffing due to employee illnesses and current staffing levels. We're also talking about the multiple electronic health record systems, which we're currently working on. However, they're not interrelated, so that we've identified as a risk. And still working towards just culture as an organization to ensure the mindfulness and best patient and employee safety and improving that quality of care for all. A focus with organizational culture. I know Tim will speak a little bit about that, but it's really focused on communication and customer service across the board. Our education department is working with our human resources department on data issues from transfers to brand new employees and that data flowing into HealthStream for education modules. And that's making significant strides. So kudos to the HR team. For our medical staff office, we have 249 total credentialed providers. In December, we have 4, and you can see the different areas listed. Also, we have many in progress files, including 15 reappointments. And Qualtrics. Qualtrics is our new patient experience data platform. So these are the new dashboards that are being built. And you can see the counts right next to them. Would they return? We had 400 and I believe it says 432. And that puts us at a 4.61 average is how patients are scoring us that they would return to Would-be Health. And you can see by the other stats, but definitely developing these dashboards with providers and leaders. So we can really build them for patient experience data to get back to really act upon the data that's coming in. Questions on Qualtrics? Or any other question?
Any other questions?
Good numbers. 4.61.
4.61.
I like it.
Thank you, Shannon.
Thank you.
We'll move on to our IT report, followed by the facilities reports, like Tim Walder, our Director of Facility Services. So you're on, Tim.
Thank you. So I'll start off with IT Athena. We did an Athena upgrade on December 9th. That is our electronic medical record that the clinics use for similar to the Meditech, putting all the information in for the patients and getting that through the process to get the bills. That we had to do an upgrade. We were required by CMS. We did as part of the meeting their requirements so that we get the funding and reimbursements through MIPS. That went, actually, we had a pre-planning meeting. We involved providers, all staff, IT staff. It was a great team effort because it's a big undertaking. We were able to keep the walk-in clinics open during that. They went to downtime procedures. On Sunday, we had a meeting to see if we were ready to go live. Later in the afternoon, we were able to, the testing all panned out, went really well. We did have some issues because of the attacking everything from the front and working together as a team and the great effort that happened. For the most part, it went very well. We certainly did a complete upgrade in a very short period of time. We did not receive from Athena the testing program until just days before that weekend, and then we did not get the platform handed back to us for testing
until 8 o'clock on Sunday morning. So it was all jammed in there to get everything done and verify that it was working and try to start identifying the issues and working together to get those corrected so that we were able to, open up clinics on Monday morning and start seeing patients again and putting documentation into the platform as normal. So it was a great effort by everybody and went very well for the most part. And it was a good precursor to when we do our Meditech upgrade, and then we'll have one EMR for across the whole organization. So it was a good practice run, but it went well.
Out of voice and your all the people involved.
Yeah, it was IT in it, but it was a lot of, people from all the departments that were involved, from clinical to registrars to, like I said, providers. Dr. Demler was involved and everybody did a really great job working together and communicating, so very well. As far as facilities, we, on Monday, the 12th, the seclusion room was handed off and was given to the emergency room to start using. So that was very positive. DI for the new fluoro, X-ray and CT, those drawings have been completed. They're in with the town of Cookville for review and Department of Health. So hopefully we get that completed soon. And then we can get that project bid out. We do have a $500,000 HRSA grant to cover that. I learned this week that from the foundation, they have $400,000 that they had raised for when we were looking at doing an MRI CT suite. They're going to let us use that money to help cover any overages that we might have for this project, because we do have to bring some of these rooms up to today's codes because of the amount of work that's being done in them, which is kind of driven the cost up a little bit. The equipment we get is part of the Siemens contract, so we're getting over $1 million worth of equipment that is just part of the existing contract. So, wound care, we're working on a room. Dr. Minnow, who will be starting on the 27th in wound care. Get a new office, so we're doing some rework in there for some of the spaces in that location. And on the 22nd of this month, we will be getting the UPS for the new the CT, because our power conditioner that was there has failed. So right now the unit's sitting unprotected. So we have a new one coming in prior to the new CT coming in, but it will support both. So that work will be going on very soon. And and then the unions, we have wrapped up those negotiations. We've given them everything. It sounds like everything will be voted on and approved, but we're still waiting to hear back. They have everything that they wanted, but the feedback has been very good. So it went very well with those union negotiations. And one other little thing we're working on is Remy is a company that can, through WISHA, through the support of WISHA, can help reduce some of our contract costs. So like right now, Agility is our biomed. They manage all of our patient safety equipment, and they manage a lot of those contracts to keep them an inventory of them. And when they come due, and then they give us options of, can we put this piece of equipment under Agility or under the manufacturer for ongoing service, or maybe bring in another third party. But in it, and we usually see a pretty good savings when they do that, because they're a very large organization. But Remy can go a step further, and we've been sharing some of the contracts with them, because they've been giving us some of the preliminary pricing. And for what we're seeing so far, we're seeing anywhere from a 15 to an additional 25% reduction in those fees. So another very positive thing moving forward. But at that time, that's the end of my report. Thank you. Do you have any questions?
No, there again, I mean, as we're going through these, it's amazing, every department is basically short staffed. I mean, I think throughout. But it's amazing on every department that we deal with, how people have stepped up, and this whole turnaround, getting the hospital going in the right direction. I'm still just amazed with the whole staff as to how many people are stepping up and making things happen and working as a team. So it's kudos to the whole group, throughout the hospital. It's amazing to watch what all, like I said, what do you do on your spare time? Each one of you. don't want to pull out one department over the other. I mean, every department that I see, people are just diving in and doing a huge amount of work with a small staff and we're shorthanded.
I do have one question. The rebuild and update for the GI diagnostic imaging. If you need more monies, would this be something that the USDA loan that we have, since it's internal, could be used for?
No, unfortunately not. That's allocated for a project. A lot of that is infrastructure. And then, as we identified some phases that we could do in addition. But that is basically a full-blown project that would involve other projects, but not this.
Is there a time limit on which we still have that loan, or if we don't use it by 2025?
On a quarterly basis, I update Darla O'Connor with the USDA and let her know where we're at. They don't generally take them back. It's there when we're ready, as long as we keep them informed of where we're at in the process. We are constantly having discussions, Mike, Neil, we're involving everybody. Shared the facility master plan with Paul. It's just a matter of when we are financially, because we do have to take on some liabilities to start anything. And then also determining if we need to change the scope. But no, there's no timeline as long as it's there.
Any other questions, Kim? Seeing none, we'll move on to our nursing report. Curtis, our executive director.
Just like everyone else, we're doing busy. The staffing plan is something that has to be turned into part of the health yearly. It's part of our application renewal. That process starts fairly early. We started meeting with our staff committees for the different units. And then once we have come up with our proposal, then it's presented to our staff committee with the union, the USNA, that's part of their agreement. They bought up on it. And then I had to find the time to make it look pretty and in great format. Got that done, and so that's been sent off and caught Mike in the parking lot, please sign it. I want to get it out. And so that's been done. In addition, I wanted another huge undertaking is our trauma application. It's due every 3 years. It's due again this year. And excellent work has been done by Kate Waterman. She's an EWRN, Debbie Reedus, and Bert Ballard. I worked very hard to get around it. We did have a trauma coordinator who did not complete things needed on it. So these three individuals did a lot of work along with Terry. Garrett, who's no longer here, she stepped in when she was here to try and bring these current. We're sitting really good with that, and that application was signed today by myself and Mike, and it will go out on Monday. And that application is actually in the reading binder. It's I read it to make sure it was compliant, and it's like, wow, very detailed and a lot of work. Luckily, we don't have to do that 3 times a year. I mean, every 3 years. Oh my gosh.
Level 3.
Level 4. We did drop down to the level 4 earlier in the year. And that was primarily, we were not meeting compliance with having ortho available. And the decision was made to go ahead and do a level 4 because at a level 3, there is an on-site survey that is very intensive. And we made it through that. So knowing that we weren't meeting those guidelines, I wrote a letter to the state and we dropped down to the 4. The DMV always have to plug for nurses because that's who I manage, but nursing did a phenomenal job. They do an in-depth review of charting and titration of drugs and blood administration, and the charting was good. They're also the key point that they're looking at are plan of care. That's a big trigger now for a lot of organizations. And it makes sense in the plan of care is what is our plan to achieve the outcomes that the patient goes home? What are we doing? And plan of cares can be time intensive. In nursing, it's one of the things that we don't like to do. In school, we hated writing our nursing plans, but they do serve a good value. And the DMV looked at
if someone's in restraints, do you have a restraint nursing plan? Anyone in violent, you have them here, they're diabetic, do you have them on this plan? So it's very geared individually towards the patient. And they work us with the nursing plans. But that's been a hard road coming, re-educating, getting into the nursing staff, and very pleased with the outcomes on that. Telehospitals. Talk a little bit on that one. You know, I think with any new program, there's always going to be some bumps and I know pun intended, because it is a nighttime program. And we have an additional advantage on our hospital that we have Dr. Rangel as part of our day hospitalist, because she has worked as a hospitalist for Sound, understands their limitations, understands what they can do, and the workflow. So that's really helped us as far as working together as a team with hospitalists and nursing staff to say, okay, we need to adjust their expectations a little bit either way. There is a difference, they're not at the bedside. But overall, it's gone fairly well. Those are things that, you know, you look at the cost savings, it was nice having a doctor here, but the amount of usage that we're actually getting, we're telling how there isn't a lot. The day hospitalists have worked very well together to say, okay, this is going to be a transfer, and the other people are ready and done before I walk out the door. So we don't have to deal with the telehospitalists. And they're also working until even restraints, whether they're restraints nowadays. The telehospitalists are, no, I can't do it face to face. I don't want to even do a restraint. Well, that is a huge finding for survey on restraints. So now our hospitalists are actually at 1 o'clock every day are going in and notice the date and time renewal. And the restraint, they're setting it up and renewing when it's appropriate. So we're not missing any of those deadlines. And that has helped with the workflow and frustration, particularly with nurses who take it on themselves and ownership. Gotta get this done, gotta get it done. It's going to be a problem if we don't. And not having to work with the night hospitalist and that. So it's saying, we can do this, no, we can't. Here's who can do it, when and where and how. And so that's really come to fruition. It's also been a little bit different, and I will be formalizing a policy for the smaller things that we might need to tell a hospitalist at night. As a rule of thumb, we, as nurses, and it's best practice, and CMS has told us this, do not take verbal orders. However, when you look at the hospitals and what they're doing, and going around at night and punching in, it may be best interest to take care of the patient at night and have that verbal order and follow just like anyone else. They can sign off on it for the interest instead of this constant at night. The numbers are so few. I think for efficiency and patient outcomes, it makes sense to go ahead and look at that. So we'll be looking at that policy so that we're in compliance and it's not a free for all for everyone. There was one hospital, and I had to do an admission. No, that's not a verbal. That is, you need to get a computer to do that. That's too much liability. So communication has been key. It's working very well with that. And Shanna's a great partner in that. So is Dr. Rangel, working together. And that's what I really appreciate at this point, is that the team's working together and we're solving things as a group across the continuum with a process and not just a fixed outcome to the command. Staffing. The good thing I will say, it may not be the type of mix of staffing we want to get. This is a combination of FTE and travelers. That as of the second week in January, the emergency room will be fully staffed. Fully staffed. Now, what my intent is to be, we do have 4 travelers that will be in there. We're going to work with Lahala, who has been a great addition to HR and is really opening a lot of doors for us, and I appreciate that. I really expect by March, we're going to be able to fill our positions, and as these travelers contracts expire, we'll be able to let them go without resulting in any vacancy. So that is the goal, is to keep them here as well. It also allows us, because some of them will be here until March or so, gives us a little more flexibility if we bring some in who may not be a full-fledged ED nurse. We've got the manpower to bring them in and we train them. So by the time they travel, they're ready for work. So that's where you're looking at a little bit different. Dr. Miller and I had a great conversation with another platform, Utility Dogs. Looking for alternative delivery channels for the ED. It's understood that our delivery model has to change. Our methodology of how we provide care and today is becoming antiquated with the new demands and shrinking resources. And I'm going to talk, we haven't had a chance to talk more, but there's some other alternatives in there that we might review as well to increase efficiencies and patient satisfaction, even for those that are waiting. One of the nurses I interviewed the day before for ED, she's going to be short. She was a charge nurse in the ED of a 47-bed ED. Their waiting room had anywhere from 80 to 100 patients. And their average wait time is 24 hours. That gives you an idea of the magnitude of what's happening in our country. Now that was granted was on the East Coast, but that's what's happening in our country. So I think at this point I get a little goosebumps because I'm excited because this administration team is agreed we've got to look at something different. That we're ahead of that curve and we don't have the 24-hour waiting period. But those of us who've been on this island long enough, 3 to 6 hours waiting period in our ED is extremely long from what we were accustomed to. Same thing with the walk-in clinic. So I don't think we one size fits all, but it is looking at different alternatives there. And we educate in our community. We also had I've got 2 FTE new hires, one going into ICU, did a permanent placement with us, another one into med-surg. And with that said, we'll be short our house supervisors. So looking at how we want to manage that, there will be one person to do 7 days a week, and I will be the second person thrown into that. So that's going to take me into nights from now. I'll probably reach out to some of the department managers and see if they can pick up days here and there as we work to fill that. The other shortage that we're looking at is social work. That's another commodity that's really hard to come by, but it's a huge service that has to be had here in our organization, particularly as we look at trying to get people transferred in proper care and set up at home. We're looking at that, and even some of the clinics are asking for support from social work. So that's another rock that we're trying to overturn, and Paula's already stepped in and all of that. So as you can't tell, Paula's my new best friend. She was a friend from years ago when she worked here, and this is a good a friend, if not better, now that she's back. So I feel very thankful and fortunate to have the people we do, because we're working together as a team. And the only other thing I wanted to mention a little bit, Shannon, talked about COVID, and I wanted to bring it down home a little bit and tell you what it's doing here in the hospital. So right now, we've had 17 staff members positive for COVID in the month of December. We had 19 for the month of November. So you can see how it's really starting to ramp up again. And we've all seen on the news how there's a different variant in China and what's happening there. So back down the hatches. China's rolling back 2 years worth of restrictions, going back to where they were 2 years ago when it started. So I don't know what that means for us, hope it'll stay, but we need to be prepared for that. The other thing you look at is influenza, and we see that it's tenfold, but we also need to remember that for 2021, we were over the net. So our natural defenses against influenza A have been down. And our lab, as of Monday, had already confirmed 50 influenza cases. So that's on the rise, along with 13 RSV. So the respiratory diseases are on the climb. RSV is hitting our little ones very hard. And it's hitting our staff members too, because not only are we getting staff members with COVID, but we have a lot of workforce that have children. that are now getting RSV and COVID and this stuff. So you couple that along with staffing shortages, it's been challenging. But again, the kind of staff that we have working for us is tremendous, as evidenced by the quality numbers and politics that Shannon shared with you. Despite those challenges, this team and everyone works together to keep our outcomes the way they are. So I'm on my soapbox.
So with the current staff, how many beds can you cover, and does that include the swing beds?
Swing beds. If staff didn't call out or decide to have meetings or surgery, it takes them about 3 months at a time. Right now, my staff on med surg, I could do 15. The problem is I can't keep the staffing high enough on all 3 shifts to be at 15. So we're holding at 13. Problem with that is if I get a call out, we're really in trouble. That's where we're running into is these costs. And case in point, that's why the ICU manager gets staffed in. Debbie Reese, bless her heart, staffed in a lot. I staff in a lot. The OB manager is staffing in a lot. So on top of doing just our regular jobs, we're also doing bedside care because we can't keep. And that's at our reduced bed count. In the perfect world, the hospice can take about 20 patients. So we're looking at a combination of 17 med surg and swing combined and 3 to 4 ICU. And ICU in January, we think we'll be able to open back up to 4 beds, which is important because we've had patients that we need to go to a higher level of care, but they were infected, they're vented infected, and the care they needed we couldn't do. But moving to the ICU anyways is to take care of them because it's better care for someone on a vent than in a busy meeting, and it's better for the family. So that's part of when you look at the expense, the FTE, we are sacrificing revenue because we can't. And I fight pretty hard on that because Providence does go above and beyond. That's where the head nurses work out because they're throwing away over the shows.
How many borders do we have now?
In the ED, we have 2 and 1 on med surg. And that's the true definition of a border. Border is someone who needs is waiting for placement, medically clear. The other thing we look at sometimes when we hear, well, we have 9 borders, it hasn't been really 9 borders. It's because 5 of them are waiting to be admitted to med surg. And so they're counting them as borders and they're waiting to be in med surg. So right now we don't have any pending. We've been able to turn the beds fast enough. So it really is, and that's when you look at short staffing everywhere because, for example, today we only have 1 housekeeper with the buildings. So if you're trying to turn these beds really quick, it's getting difficult. So it's an organizational thing above and beyond just nursing. Any other questions?
Any questions for Curtis? All right.
Thank you, Curtis.
Always good to hear from you and where we're at.
Thank you.
Moving on to our HR. Yeah. Mike, you're on the list here, but we're gonna go to her.
Thank you very much.
Bye now.
Not more important than
Better looking than you.
So thank you and good afternoon. I have now been in my position here back at the hospital for 4 weeks. And in the last 4 weeks, I have been and will continue over the next 8 weeks to assess whether or not the HR needs of the organization are being met and identify where we are being successful and where maybe we can make some improvements to deliver better service to those that staff here that we serve. One of the primary focuses this first 4 weeks is to recruit and build the HR team. At one point, recently, we were down to 1.6 FTE in the HR department. We would need to staff up to 6 FTE in the HR department. So we are currently focused on staffing up. Like, we're no different than any other place in the hospital. Where we've had some critical staffing shortages, so our focus has been on recruiting HR team members. I think that recruitment and retention of staff as at the end of my 4 weeks is probably the biggest priority as we're looking into going into 2023. Our KPIs are minimal for recruitment metrics and retention metrics. So what I have to report out is that in the month of November, we had 20 new hires. We had 20 people that were brought on board. We also had 20 terminations. So we did not gain any ground on our turnover. So we have a year-to-date turnover, and we don't need to show that. No big deal. Mike told me I could just talk, which is way better for me. Instead of having a slide, and I wrote notes, so I would talk too long. So the thing is that our year-to-date turnover is 27.18%. This is in line with the national average at the end of 2021. So in the 2022 NSA National Healthcare Retention and RN Staffing Report, which is pretty widely used, in 2021, the turnover rate was 27.1%, which interestingly enough, in 2021 was up 8.4% from 2020. So if you think about, the effect of the pandemic, the COVID, those kinds of things. The other thing that I've noticed since I've been here is like Curtis was talking about, which is we're having a hard time recruiting for, say, the emergency department. So when you look at the statistics over the last 5 years, the national average of turnover in an emergency department over the last 5 years has been 111%, which means then emergency department staffs are completely new every 5 years. So while I hate to say we are right there with everyone else, we are right there with everyone else. So what are we going to do here at Whitby, right? That is different. The other thing that I think is important, another important number as far as national average, and this is not a KPI we currently track in our HR department, which is different. They call it difficulty to fill or time to fill. So the average time to fill to recruit an experienced RN is 87 days. So when we have an RN opening, the minimum amount that we can expect before someone will be in that position is at least 90 days. So that also adversely impacts our ability to care for patients. So I think another thing to think about when you're thinking about turnover is not just people leaving to go somewhere else, but what does our applicant pool look like? And our applicant pool is shrinking. Over the last 3 years, many nurses have decided that are retirement age have retired. Many of those that are close to retirement age have decided to retire early. And there was a recent survey in November of this year. They surveyed 1,000 nurses, and over 500 of those nurses said that they were considering leaving the profession. So again, not leaving their job to go find another job, but leaving the profession. And so the top 4 reasons are working chronically short-staffed. Because they're working chronically short-staffed, they don't have enough work-life balance. They're picking up extra shifts. They're not here as much, or they're not at home as much. Burnout is a risk to their mental health. And they don't feel like they are being seen or valued or heard, so a consistent lack of recognition and appreciation.
With the exception of you.
I'm sorry?
With the exception of you.
With the exception of the health. But I think it's important to understand though that we can probably do a better job in all of those areas at Whitby Health, right? So my initial response to the recruitment and retention strategy, which I am in the process of developing, is to, first of all, hire a recruiter with healthcare experience. Recruiting in the healthcare space is different than recruiting in other spaces, so that we can actively recruit and market Whitby Health, right? We have lots to market. There's lots of reasons to come here and live. So we have a recruiter, a full-time recruiter position posted. Shannon and Curtis are being very innovative and we're considering adding a 0.5 FTE to our education team to be able to provide additional support to those UB Health staff members who, like every other person, is experiencing stress, anxiety, burnout. So Shannon and Curtis are really doing some outside the box thinking about how can we provide additional support to those workforce members. I have created an initial recruitment plan, and once the recruiter is on board, we will finish the recruitment plan that we'll be able to share and be very transparent about, and also review it quarterly to make sure that it's effective and we can modify it accordingly. We want to develop and deploy an employee engagement survey in the first quarter of 2023 to see how our staff are feeling about their work here at UB Health. It was Mike's vision to have that done before the end of the year, but because of the I hate to say lack of bandwidth, but because of some other things that were considered a little bit higher priority, more of a crisis situation, we did push that out to first quarter of 2023. We want to reinstate or develop new or enhance our current reward and recognition programs. And then also it's important, I think, that we are able to establish true and best practice recruitment KPIs so that we can use those to measure our success, to monitor our success, and be able to give a more robust report to the board. So, any questions?
Any questions, Laura?
So, just recently, Mike and I and Jamie walked through the ER. You know, just to let them know that, you know, we're there, we hear you, you know, we know you're having concerns. Now, do they work 8-hour shift or 12-hour shifts? 12. You know, and so like for us, you know, we made it there during the day shift. I don't know if that'd be a good idea, you know, even like a couple of board members with Mike. We walked through the ER, you know, try to work it out where we can get the night shift too. But just to let them know that, you know, they're not forgotten. You know, that these issues are coming, you know, Curtis is bringing them to us, you know, all the issues are coming to us, but they don't really know that, you know, that we realize that they're shorthanded. And so I don't know if there's something that we need to work together on so that, you know, once a month, once a quarter, we actually walk through, you know, it's one thing to do rounding with med surge. You know, the ER is a little bit more difficult, but we don't want them to feel forgotten either. So we might think about that, what we can do, you know, with a couple of board members, along with Mike, that, you know, it would be a good thing to walk through there, you know.
I think that would be great. I will share with you that I do send a email and communicate with Debbie the names of the start dates of people, and she's sharing that with the staff. So at least they have something to grab onto and say, okay, focus going. The thing is, it's been very hard. We have been trying to staff the ED for about 6 months now, and it's been very difficult to get them. And it has come into cost. We've had to increase our travels to get the travels in. But again, I think it goes right back to what I was saying is that, and I've shared that in our management council meetings. The workforce is shrinking. People are not just leaving the hospital, they're leaving nursing. And there was one point, I'll be honest, I thought about it as well. I thought, I'll go back to my previous career. And it was just fleeting thought. I didn't do it, but being honest, it's become a very difficult job, very demanding. The clientele is different. And you can see in the workplace violence. I mean, there's a lot of violence against nurses, you know, a lot more than there were 13 years ago. And so the workforce is different.
3 years ago.
I would agree with that. Yes, I honestly, pre-COVID, now it becomes right line on it.
There again, I mean, we just want to support the staff. You know, it's not like we're gonna go in there and resolve anything for them. You know, I mean, we can hear their concerns, but we're gonna just rely on between Mike and the managers to take care of issues.
Your visit,
But it's just more along the lines that they know that that things are coming to us. That's what we try to tell them up there too, is that, we hear it, Kurt's gives us presentations all the time, we hear what's going on. And it's not falling on deaf ears. I mean, does it
and I
matter?
will tell you, your visitation that you did, and there's a lot of good feedback. From that.
Yeah.
So, yes, please, if you can, please do that.
Like I said, we're not trying to micromanage or undermine, what you're doing. It's just letting them know that, the board's aware of your issues and, we're working closely with the staff to rectify it.
Much appreciated.
I don't know that I've ever thought about anybody could be overappreciated or overseen, right? And I think that your visit did, I know it meant a lot to me. I mean, when I heard that you were at the emergency department working with, because the reason why I'm here is because of the people who work here. I have a lot of respect and a sense of responsibility. So it meant a lot to me to hear that you had gone up and done some rounding in the emergency department. And I would encourage that. The Board of Commissioners being visible and knowing what's happening along with our Chief Executive Officer, I think is very valuable. And I think that the downstream effect of that we might not even see.
Latoya, it's Greg Richardson. If I could ask a question.
Go ahead.
You might want to consider a small task force, not a long-term Tiger team of such, maybe in the first quarter, to look at intrinsic rewards, recognition and acknowledgement from the standpoint of departmental, because obviously each part of the hospital has specific and sometimes generalized types of things, and get people's opinion on what would matter the most under the principle that people work for acknowledgement, they take home paychecks.
I will tell you, I've had two staff members who we have already, with the Just Culture and Change, who have received thank you notes at their home and sent to them, mail them out to them. Came in and said, "You didn't have to do that meant so much," because it was personalized and it was sent at home. So we're starting to do that kind of stuff. It is, most of the times when you're talking to staff members, it isn't the money's part of it, but a thank you card with a cafe voucher, and it went a long way. And so that's a start. It's going good, and I'm thankful that we get the support. Do that with the meal tickets too, because it makes a big difference. We're all busy, but it's important to take the time to stop and thank people personally, and then put a note to when they've gone out of the It's going along.
And if I can add, if you round patient access as you're coming into the ED, I think it's as impactful. I went up there to round on my way out about 6 last night, and patients are very frustrated with the wait times. So they're consistently having to communicate, "I'm very sorry, we're working through, I'm getting to you as fast as we can." But that's a very difficult job in that moment, and they're constantly coming in the door just frustrated. So it just speaks volumes with you all rounding.
Yeah.
Administrative report. Mike, thank you, our interim CEO.
Good evening, Mr. Chairman and Commissioners. I'll make this as brief as I can. Just want to highlight a few things that we've talked about here. When we first came on board back in March, January, February, March, we had a couple of goals and directives from you folks. One was to improve our financial position. I think we've done dramatic improvement in our financial position. Another was to improve medical staff relations. I think that's been done for the most part with the medical staff. Another we just talked about, another directive was open the Freeland Clinic. I think Mr. Golden mentioned that to me about 25 times. I said, I've heard that. Have some patience. We'll get there. The reason we closed Freeland Clinic was staffing. We just couldn't find it. So now we've found staffing, and I think this is great. We're going to improve the access to primary care for the people in the South End. It's a wonderful thing for them. Another thing was, let's make sure we get our accreditation through DNB done. We should receive formal accreditation certificate to hang on the wall here in a few days. We had about 4 deans, I think we mentioned that, 4 things the deans are, things we need to improve. As opposed to, Tim mentioned to us about 44 issues that we had 2 years ago when we came through, so great progress there. So thanks to this team, done their teamwork. One of the things I just want to highlight too is we had a very productive meeting with the Navy base just a few days ago. Curtis and Tabitha and I went out to the Navy base. We went out to improve communications and access and just have some partnering activities to look at. So we came away really excited about the meeting. We met with Captain Altoff and Captain Hanks out there. And what we walked away with, just to be brief, is that we agreed to help their RNs receive some clinical training for readiness out there. They need about 2 or 3 weeks each year, and they've been having to travel well out to get that. So we're going to have their nurses out here. So that's a really nice partnership. We found out that they have a quality of life meeting, I think once a month, where they talk about all the services on the island. And one of the things they talked about is that we do not deliver babies or have OBGYN services at this hospital, which we do. So it's just, how did that happen? No one knows. But Captain Hanks sent out a directive right away to let everyone on the Navy base know, and especially new folks coming in and out, that we have a great OBGYN service here. They closed theirs down about 2-3 years ago. And so that was a meeting.
We have some of the nicest labor delivered rooms around the whole area.
So we agreed to that we will give them a tour of our place. We received a tour till we walked around and looked at their clinic. So they're going to come here first of the year. And we'll give them a tour along with Bonnie and some other folks. So that worked out really well. And then the most significant thing that came out was that if you remember, we met with a DOD doctor, Mr. Goodman, who is controller and works for TRICARE and some other reimbursement through the Navy. And so what's come out of all this is that TRICARE, we found out, will help us through something called an impact fee. They will selectively go in and make some changes, because we felt like in that meeting, and I think Greta was there, that TRICARE is not going to make any increases for the whole United States one time. I think we said it'll take a congressional act. Everybody got a big kick out of that, because that's just not going to happen when TRICARE is focused on decreasing their costs. But there are selective towns and hospitals that they do it for. So they have provided us with information where we can plead our case, and they think we got a great case to give to increase TRICARE rates just for this hospital. So that was a big deal. Curtis helped out a lot, and Tabitha was out there with us to talk about the behavioral health side of things, which is a big need for them. So that, I think that's the big thing to say is that, and I want to say thank you to La Jolla for really focusing in on giving our employees some education to help them with stress and anxiety and burnout. When we talk about, and I just mentioned a while ago, that we lost $2.57 billion in this state this year so far for all of our hospitals. Last year, 1.66 billion, which means that we've got a shortfall that the cost of taking care of patients exceeds hospital reimbursements. That's really what it means when we say that we've lost this money. But we also talk about the massive labor shortages. We mentioned that, we said we can't staff right, but who's really affected by this is our employees. They're suffering burnout. They're having to work overtime. Rather than working 2 12-hour shifts or 3, they're having to work 4. They're coming in on their days off on the weekends. So we really need to help them with some education and how to deal with burnout. So that's what the flip side of the fact that we can't staff our employees is going through this. So we need to let them know they're valued. We need that we care about them by doing whatever we can to give them some education and help with burnout. So thank you for bringing that up. That would be fun.
Well, along those lines, I mean, one of the things that we've stressed and we've heard is that when we're putting out the priorities, we need to put retaining above recruiting. As far as, so the people here see that, you know, they are the top of the thing. We want to keep them. We're not just concentrating. Some of the hospitals have gone out and been signing bonuses and everything, which has come back to bite them. I think the main thing we want to do is make sure that when everything we send out, priority is to retain the ones we have. And at the same time, recruiting, but that retaining part is so important to us that we don't want to lose staff. So just, you know, sometimes when you're putting literature out or anything out, just keep that in mind that when people see this, that we want them to realize that we want to keep people that we have. And Mike, at this time, do we want to go into the contract?
Yes, we have a contract that we're, as Paul mentioned earlier in our report, we're trying to shore up numbers, make sure everything is correct with all of our financial statements. On our balance sheet, we have a lot of work to do yet. It's not quite where we want it. So we'd like to bring in someone to help us do a reconciliation of the balance sheet and analysis. Probably take 3 or 4 months. So we have a contract in front of you that we would like to have approved.
We make a motion that we allow the CEO to initiate a contract to hire an interim remote director of finance.
And then based on the project work order number 4, correct?
Yes.
And that will be signed by you once the board approves.
Once you
it.
approve.
Okay.
I would second that.
Okay, any discussion? All in favor?
Aye.
Aye.
So moved. The director, please go forward, sir.
Thank you.
Okay, at this time, we need to go into commissioners' comments. And if you don't mind, I'll start it off, ma'am. Kind of a sad note is, and I understand it, is that Dr. Kammermeyer has submitted her resignation as the board of commissioner. Basically, I'll read it. She says that now that would be health seems to be in good hands and moving forward, I believe it's time for me to tender my resignation as a member of the board of commissioners. It has been a rewarding experience, and hopefully my background rendered some meaningful addition to the board during my tenure. That said, I would like to tender my resignation effective 31 January 2023. I understand it. It's very sad. I do want to say that it has been an extreme pleasure to get to know Dr. Kammermeyer and to work with her. She is, I love the questions that she brings. It's well thought out. You know, it does call people up to really come up with a good answer. It's not a whole random list. It's very meaningful. And so, like I said, I really appreciate that part of it. A couple other quick things is that nobody has noticed that she did make our paper, Seattle Times. There's quite an article on her, which we do have on display now up in the lobby in our trophy case up there. But I would like to make a motion that we give Dr. Kammermeyer round of applause just for what she has done and what she has brought here. So just want her to know that we're going to miss you greatly. So I would love it.
I think this is, I mean, obviously, the experience of the past years have been up and down, but the timing of it is so that the board can select a new person to work with them and who will be around to help make decisions on the incoming CEO. Also that as a board member, that they will have 3 to 4 months to become part of the board to determine whether or not they want to stand for election and to file for that position. My tenure was going to be up in November, and it's much better to have an opportunity to work with people while you're sort of in an appointed status rather than just a name on a ballot that people may not know. And so there's the uncertainty of that. So I do it with foresight, hopefully, that you will all be part of the selection process. And therefore that you will be able to fill whatever gaps you feel that would be useful for the hospital in the future.
As soon as we can do that is in February.
We have learned
Yeah, we have.
that you have to get out of here to bring a new person in. So that is another reason for doing this sooner rather than later. And hopefully some of the people.
Dr. Kemmeyer has basically, talked about the fact that she would still be involved in, dealing with some of the VA things and the Board of Health. To do a really good transition and to, help us get through all that. So she'll be like a community.
I still live here.
Yeah.
But that's, as you bring that up, if we can, you can make decisions about who's going to take my place in the Board of Health, then at the next Board of Health meeting, I could introduce that individual.
In the interim, I would love to be part of that with you.
Yeah.
Going to that, that's the one that I have not been on.
Yeah.
And I would really like to, feel that so we put together a really good plan. You've done a great job there. I don't want it to fall off from what we accomplished there. So I'd really like to work with you on that moving forward. So I think the first meeting in January now, right?
Yes.
Anyway, like I said, I just really have appreciated all of her input and working.
You still have January.
I know. I've got January to talk about it. No,
No,
but-
that's not gonna happen.
no, like I said, so
Next time.
just wanted to take a few minutes out. Thank her for all of her input and things. The friendship she's created, so.
Mr. Chairman,
Yes, listen.
I would like to say, as a new commissioner, there's a learning curve, and it's a very steep learning curve. I would say 2 to 3 years to even just get a blemish of what you really need to know as a municipality. And the one great thing that I appreciate about you is your institutional knowledge and how much you have really brought forth all the good things that we can do for our community. And I just want to tell you that I really appreciate you very much, and I will miss what you contribute.
I think you're so thoughtful about the hospital and the understanding of the nursing, and I think is very important. That's a vital part of our whole hospital and doing that. And as he says, the institutional business about the VAs and your relationships also with our federal government as well, and all the things that you've accomplished. I'm always constantly just amazed by your understanding and also your compassion for the work you've provided for us. So, thank you.
I'd like to make comments. You ready to set high standards and high goals for us, and we will continue those. And a lot of times, when I'm ready to make a presentation here, I say to myself, now what's Greta going to say? And what question is she going to ask me? So I'm trying to be prepared because you will always have a question. So we thank you for those questions.
Greta, for me, Greg Richardson, I want to thank you. While Jim Golder is a new commissioner, I am the newest commissioner, and you've been very, very helpful to me in terms of your sentiment, guidance, etc., as well as your service to the organization. So we're going to wish you well, and you'll definitely be missed.
Thank you.
Can I add one thing?
Yes.
I just think you've been a true impact on quality for Whitby Health. You've been so impactful on quality improvement committee, collaborative, and trying to be prepared for your questions, just like Mike said. That's my goal. So thank you for all you've done.
It was. And it has been a pleasure
working with you as well. I've got-
Don't we have a job for me afterwards?
I was about to say, I'd say, you've been a great nurse advocate, and even though the name of our hospital is going to take with you. If not, I can get it to you.
So we're still in the commissioner comment. Is there any other comments the commissioners would like to make or address right now before we move on?
I would like to add one comment to back up yours, Ron, and that is the emphasis on retention versus recruiting. 26 years in HR and professional development taught me several lessons, but one of the foremost is we rely far too much on recruiting and far too little on retention. And when the chips are down and the pressure's on and the burnout's high, that's the time that it's hardest for people to demonstrate individual leadership and support for their folks, particularly at the more senior levels. So I'm hoping that LaToya and everyone else can really cut it out in the next 3 to 6 months and emphasize that, because it is the small things that'll make a huge difference in retention. And then we can spend the money we have to on recruiting.
John, is there any public comments? Pepsi?
No hands raised, no, I mean, Dr. Lemmy left a little note. Think about it. Yeah, I did. You know, going through the financial situation, and I have come to the realization that sometimes really good heroes are unrecognized. Thank you.
Time's up. Sorry.
Yeah, sorry, that was a timer. But I have come to the realization that if we had not passed the levy, our hospital would be in extremely serious condition. And I have to look back and see who really worked on it. And Kurt Blankenship was a commissioner at the time. And he went a long ways to pushing that levy through and helping this hospital. And I don't think he ever received recognition for that. And in my eyes, he is a hero for doing it. And I would like to recommend that as the board, we write him a letter and tell him how much we appreciate the fact that basically he had a major part in saving this hospital.
I don't think that needs to be a motion. I think we just need to do that.
Yeah, and I think we should.
Start drafting. So is there anything else? We do have a workshop coming up for January 5th, which we'll be hoping to see some information on potential candidate.
Sure.
And then the next board meeting will be Thursday, January 19th at 12 o'clock. Other than that, would you like to be a motion to adjourn?
Make a motion to adjourn.
Second.
Second. All in favor?
All right.
Thank you, everybody.
Thank you.